Yeah, well, Saturday, Sunday is free for me. Yeah, mostly I will be available. So yeah. Okay then. It's 12:40. We can start. Yeah. So we finished till I think here pulmonary stenosis, and we will start from. So I just wanted to before going into this class, I just wanted to give a brief view of what are the murmurs and the locations. And one of the important thing is in all murmur questions, the symptoms might be similar. The family history might sometimes might be deceiving. The third thing, but the most important thing, which will not change, which will help us with the diagnosis, will be the murmur and the location. Okay, the murmur might the location might get little confusing, so I just wanted to keep it clear. For the AS, for aortic stenosis, which we saw in the last class, the murmur is like crescendo, decrescendo murmur, systolic murmur. So to remember that crescendo, decrescendo, I make it this way, like I remember a mountain or just a peak. And the location will be in the aortic region, which will be in the left second or third intercostal space, right? So I've added a red mark here. With aortic regurgitation, the murmur will be like a blowing type of murmur. Sometimes they mention the decrescendo type of murmur, and it is a diastolic murmur. So the important thing is even with the other type of the features like blowing or harsh murmurs or crescendo, decrescendo, these things might get little confusing. But remember, systole or diastole, that is clear. So when you have a confusing adjective next to the murmur, make sure that you differentiate if it's a systolic murmur or diastolic murmur. So for aortic regurgitation, it's a diastolic murmur. And sometimes they might mention blowing type or decrescendo, and the location will be either, it depends upon the aortic regurgitation, if it's like a valvular defect or if it's like a subaortic. So based on that, the location might differ. Mostly it will be in the aortic region, or sometimes it could be one area below the pulmonary area. What happens is most questions they will not tell like if it's a upper left sternal border or lower left sternal border. They will just tell you that left sternal border, which means it could be either one of these three areas. Mostly you will not get confused with the tricuspid area. So it's going to be one of these two areas. So I just wanted you to be clear with that. Okay, so don't get confused just because they don't mention the upper or lower. And when it comes to mitral stenosis, it's usually a opening snap, but they will not mention the word opening snap. They will mention something like a sound that was eared next to it's a diastolic. So they will say it was eared next to the S2. Close to the S2, there was a like a low pitched sound or something that was eared next to the S2. So they will not mention the opening snap. So it could be anything, like even for click, even for the snap sounds, and even for S3 and S4, all these things they will mention it as a sound was eared close to the S2 or S1, or just before the S1, something like that, whichever goes with this sound. So they will not mention if it's an opening snap or if it's a ejection click or S3 or S4. So you just make sure when you hear those wordings, a sound was heard close to S1, S2, before or after. Maybe you should think all these DDs should come to your mind. Okay. And then the MS actual murmur is a diastolic murmur. It's mostly a mid diastolic murmur. They might mention the word rumbling sometimes, and the area is with mitral is like there is no difference in. I mean, the area is always clear cut. It is the mitral area, which is like the what is that, fifth intercostal space, and halfway from the clavicle, right? Sometimes they might say that it is radiating all the way to the axilla. Okay, so that word might be mentioned, but the area will be very clear, so that you can differentiate either it's a mitral stenosis or mitral regurgitation based on the murmur. Okay, and then one more thing is mitral regurgitation. Mitral regurgitation, it's a systolic murmur. Okay, but remember it's a hollow systolic murmur. At this point, I want you to give me the DD for hollow systolic murmur. Can you tell me what are the differential for hollow systolic? It's like just three. What are they? Okay, and yeah, VSD, mitral regurgitation, tricuspid regurgitation. Whenever they mention holosystolic, definitely it's going to be one of these three. There's no confusion in that. Okay, based on the area, you can differentiate. They're saying like the mitral area, it's mitral regurgitation. They're saying if it's a tricuspid area, it could be VSD or tricuspid regurgitation. But they're not. This is like with VSD or TR, there will be a lot of other differentiating factors, so you can easily differentiate it. But holosystolic murmur, it's a clear cut. Okay, only one of these three things will be diagnosis. And sometimes in MR, if it is like associated with MVP, that is mitral valve prolapse, they might mention a click. So MVP is the process itself in MVP is that you have a mitral valve. Okay, so whenever the ventricle, left ventricle contracts, okay, this contraction happens. If it is like a smaller, it's just MVP. There's only prolapse, but there is no regurgitation murmur. It will be this contraction will cause what you little bit of prolapse of this mitral valve into the atria, right? And that will cause a clicking sound. This is not a murmur, okay? But this, if this MVP progresses to MR, that is this prolapse now just opens. It just not prolapses, it just opens up like this, like a mouth, it opens up. Then it reaches to MR, right? In that case, there will be a click followed by the MR murmur. In those cases, it will not be holosystolic murmur. They will say there is a click followed by a systolic murmur. Okay, so remember, holosystolic murmur is going to be one of these three things as diagnosis, but they will not mention holosystolic murmur for all MR cases. Okay, you get what I'm saying, right? For the holosystolic murmur will not be seen in all MR cases, but if they mention holosystolic murmur, it's going to be one of these three. Okay, it is like a specific sign, but it is not sensitive. That's what I'm saying. I hope you understood that. So they for MR sometimes they will mention holosystolic murmur, but not all the time. Sometimes it will be just a systolic murmur, or sometimes it will be a click followed by a systolic murmur, or if they mention only click, it's going to be MVP. I hope you're clear in that region. And the region is like, I mean, the location is like the same, the mitral area. Okay. And then HOCM. The HOCM murmur is like same as AS murmur. The thing is, in AS, I told you it will be heard in the aortic area, right? But HOCM murmur will be heard one area below the pulmonary area. Remember why? Because the obstruction is not in the valve itself, but it is like a infundibular part. That is the part of the septum that is close to the valve, interventricular septum that is close to the valve. That is what is actually causing the obstruction, right? So it makes sense that it is one area below the pulmonary area instead of the aortic area. So I hope you're clear with that. And other some important murmurs, all these murmurs will be almost the same and the right sided counterpart as well. But mostly the questions will be in this four murmurs. So apart from this, the important murmurs will be DA murmur, which is a continuous mission like murmur. That I hope that is, it's like a spotter. There's no other differential for this. And then when it comes to ASD, the ASD, there is sometimes they will mention murmur, sometimes they won't. But the murmur is actually, it's not because of the ASD, it's because of the excessive blood that is flowing along the pulmonary arteries. Okay, so when there is an atria, when there is an atrial septal defect, there's a lot of blood from the left ventricle going to the right left atria going to the right atria. From the right atria, it goes to the right ventricle. From the right ventricle, it goes to the pulmonary artery, right? So it is like excessive load of blood which is going to this pulmonary artery, which is causing a pulmonic flow murmur, which they will mention sometimes, sometimes they won't. But what is classic is the white fixed splitting of the S2. Okay, that is like classic. And then I told you about the holosystolic murmur. I hope this gave an overview about all the important murmurs. Okay, so now we will go into the aortic regurgitation thing. So aortic regurgitation, when it comes to aortic regurgitation, let's see what are the causes of aortic regurgitation first. Yeah. So common etiology for aortic regurgitation could be like bicuspid aortic valve, or it could be like rheumatic heart disease and endocarditis, or it could be like Marfan's or syphilis, or even the Ehlers-Danlos syndrome, where the aortic root undergoes dilatations. So what I wanted you to clear when it comes to regurgitation murmur is that it doesn't matter if it's mitral regurgitation or aortic regurgitation or whatever regurgitation, there are two causes. Either there is a secondary cause or it is a primary cause. Secondary cause is because there is some kind of dilatation. When if there is a valve, when you dilate it, when the ventricle dilates, this valve annulus also dilates, right? And that will cause a what is that, insufficiency in the closure of the cusps. Okay, even if the cusp closes, there is some kind of gap going to be existing because of the annulus has been dilated because of the dilating ventricle. Okay, that is going to cause some regurgitation. And anything that causes anything which is indirectly affecting the wall, there's no actual pathology in the valve or the annulus, but there is pathology in the ventricle that is causing the regurgitant murmur. It is secondary. And primary is there is actual problem with the valve, that is bicuspid aortic valve, or if it is like a rheumatic heart disease where the valves are affected, or it's Marfan's disease, or mitral valve prolapse where there is a myxomatous regeneration, or endocarditis which is causing like some kind of what is that, emboli or thrombus which is affecting the valve closure. So these are like the actual valve problems, which is primary. Secondary is like there is some kind of dilatation. This dilatation issue will be seen with MI, or if there is heart failure where you see dilated cardiomyopathy. In those cases, mostly it will be like MI. Okay, so whenever you hear a regurgitant murmur, you should remember these two causes. Either because of the dilatation concept of secondary dilatation concept, which is secondary causes, primary cause of actual pathology, some kind of pathology in the valve itself. It doesn't matter it's mitral or aortic. This concept is going to be the same. Now, just the diagnosis that you fit into these concepts, the etiology that you fit here, that is what is going to differ. So when it comes to the aortic regurgitation, there are aortic root dilatation, which is like comes under dilatation concept, right? So that can cause the regurgitant murmur. So with the aortic root, what are the causes for aortic root dilatation? It could be any collagen defects, anywhere there's a collagen. Instead of the blood flowing inside, they will just instead of being a tube-like structure, it becomes like a tubular saccular structure, and the blood starts filling, and this causes dilatation, right? This dilatation itself will cause the valve insufficiency. So that, what are the causes? One is the Marfan's, that's collagen defect. Another one is Ehlers-Danlos syndrome, that is also collagen defect. And why is syphilis? Syphilis will cause something called obliterative endarteritis. Okay, I think I remember seeing these questions in multiple U World, but I didn't see anything in the actual exam. But the thing is, this obliterative endarteritis is a vascular issue. The vessels which are supplying the walls of the arteries are getting affected, and that is what is causing some kind of collagen defect, and that will lead to the dilatation. Okay, that can cause either aortic regurgitation, that can cause what do you call it, aneurysm, or it can cause dissection. All these three, so all these three concepts that I mentioned so far, the collagen defect, Marfan's, or Ehlers-Danlos syndromes, or syphilis, all of these three are causing some kind of problem in the wall of the aorta. So all of these are causes of both all the three: aortic regurgitation, dissection, as well as the aneurysm. Okay, all this three. I hope you're clear with this concept. I didn't confuse you, right? Yeah, so you just keep it clear. Next thing is the post-inflammatory. These are the usual things: rheumatoid heart disease or endocarditis, or the primary cause of any what do you call, any regurgitant lesions. Actually, rheumatic heart disease is like the cause of most of the valvular diseases. But I want you to remember that what is the most common with the rheumatic heart disease. Okay, rheumatic heart disease can be the cause of anything, but what is most common with the rheumatic heart disease? Most common is in acute phase, it will cause mitral regurgitation. In chronic phase, it will cause mitral stenosis. This is the common thing. Okay, whenever they mention a so where if it is mitral regurgitation or mitral stenosis, particularly mitral stenosis, you are expected to find a rheumatic heart disease history in the question stem, like they immigrated from somewhere, or they had a history of recurrent sore throat or something in the childhood where they never went to the hospital, something like that. Okay, so even though you can see rheumatic heart disease in all the etiologies, you just remember MS is more specific for RHD. And then endocarditis also you will see in most of the regurgitant murmurs. Okay, and then bicuspid aortic valve. There's only two valves, two cusps. So if there's only two cusps, there's not enough enough space to close it. So that can cause regurgitation. That is clear. So we will move on to the pathophysiology. Yeah. So what happens in the regurgitation murmur? All the regurgitation will cause excess blood, right, in the ventricle or the space that is above, next to the regurgitation. For example, in aortic regurgitation, blood is going to get come to the left ventricle, and this excess blood will cause what type of hypertrophy? Come on, answer it. Yeah, eccentric hypertrophy, though. So it is going to cause, yeah, dilatation, cardiomyopathy. Okay, so that concept should be clear. All regurgitation murmur, it's going to be the same. There is going to be some kind of dilatation. There is going to be eccentric hypertrophy. Doesn't matter pulmonary or aortic. It's just the dilatation is going to happen in the chamber that is next where the regurgitant blood is reaching. Okay, mostly it is going to be the left ventricle. Okay, so eccentric hypertrophy, and you will hear the murmur better in the left lateral decubitus positions. Yeah, one more concept, most important concept when it comes to the aortic regurgitation is the pulse pressure. Okay, so what happens? This is the aorta, this is the left ventricle. You have the blood which is going in, causing the systolic blood pressure. Systolic blood pressure is mostly dependent on the cardiac output, right? And diastolic blood pressure, I think we mentioned it in the previous class as well. Diastolic blood pressure will depend on the mostly depend on the systemic vascular resistance. Okay, and here you see the blood is going in. Okay, and the blood is getting after the systole, the blood is supposed to stay in the aorta, but it is coming back, it is getting regurgitated. So this regurgitated blood will cause a fall in the diastolic blood pressure. Pulse pressure is the difference between the systolic blood pressure and diastolic blood pressure. Now the diastolic blood pressure has fallen down, which itself is enough to cause a increase in the pulse pressure. But there's one more concept here. What happens to systolic blood pressure? This regurgitated blood will cause what? Increases in the end diastolic volume. Whenever there is an increase in the end diastolic volume, the cardiac output increases, but it is not the actual increase. It is like even though the blood is going out, it is anyway going to come back immediately into the left ventricle. So, but anyways, the end diastolic volume is increasing, and that will cause increase in the cardiac output. As I told you, systolic blood pressure is dependent on the cardiac output, so the systolic blood pressure is going up. So systolic blood pressure going up, diastolic blood pressure falling down. It will cause very drastic difference in the pulse pressure. Okay, and this pulse pressure, how do you see this increase in the pulse pressure? You can see it through some signs. What are those signs? The head bobbing sign. Remember, like the pressure is like dropping and rising, dropping, rising. There is this. It's going to create a vibration in the body, and the regions where you will see this vibration will be the head. One second. Yeah, it will be the head. So they will have a bobbing head sign, or you can see this vibration in the pulses, in the peripheral pulses. That is what they call hammer pulse. There are a lot of different names to this pulse. But whenever they say that this concept is the same, it's just the very low diastolic blood pressure and very high systolic blood pressure is what is going to cause this vibration. And that vibration, they name it in a different way: hammer pulse, head bobbing, and sometimes they will say the capillary pulse. They will give you some adjectives like some characteristic to this capillary pulse, and even for femoral pulse they have a name. I think it's a pilot pulse or something. So whatever it is, when the concept is the same, there is a drastic difference in the pulse pressure because of the increased systolic blood pressure and diastolic blood pressure. Yeah, so I hope this will be the one of the important differentiating clues when it comes to the aortic regurgitation murmur. Like I told you, all murmurs will have three. One is history plus is murmur, and then there is going to be symptoms will be like a very vague, because most of the times it is, in case of stenosis, it will be the low cardiac output that will be causing like exertional syncope, pre-syncope, or even exercise intolerance, all those symptoms. And while in the other the other symptoms, mostly it will be about the heart failure. If there is a excessive blood being accumulated, and that is causing a backward pressure, which will increase the congestion in the pulmonary vessels, and that can cause edema, and that can cause pulmonary symptoms or sometimes heart failure symptoms. But these are all symptoms when the disease progresses to heart failure. Okay, sometimes they might mention those pulmonary or edema symptoms and all, but these are vague symptoms which you will see in most of the regurgitant or stenotic lesions. So you cannot differentiate. It is very difficult to differentiate. But the other thing that usually helps us differentiate is the murmur and the location. And you should keep an eye on the history as well. If it is an elderly patient, like more than 60 years or 70 years, it is going to be a AS. If they mention RHT, it is going to be like immigration of this history. It is going to be what is that, mitral stenosis. So one of the extra clue that you will find in aortic regurgitation cases will be the pulse pressure. You will see a widened pulse pressure, that is increased systolic and reduced diastolic blood pressure in the AR cases. So this is an extra clue. Okay. Yeah. So next will be the clinical features. Like I told you, there will be like sometimes what they have is like they will mention like this pulse pressure can also be felt like there is a pounding heart or something. If you're seeing the vibration in the peripheral pulse, you should also see that vibration in your heart, right? So some people might have that pounding heart, but the problem is this pounding heart will also be mentioned in the palpitation cases, like atrial fibrillation, ventricular tachycardia, and paroxysmal supraventricular tachycardia. All those cases will also have pounding heart. Pounding heart also means like there it could be like a conduction problem, not just the pulse difference in this widened pulse pressure. Okay, that also you have to keep in mind. So these chest pain, dyspnea, or and palpitation, all these are features which you will see in multiple things. But yearly diastolic decrescendo movement, which we already mentioned it, and the widened pulse pressure is an important clue. And then the water hammer pulse, pistol short pulse, pistol short femoral pulse, and abrupt carotid distension and collapse. These are extra clues because of this widened pulse pressure. That is because of a sign of the widened pulse pressure. And they mentioned some other important the root dilatation like malfunction, which we already mentioned, and right upper sternal border, right aortic area, yeah, that is most common, and left sternal border at the third and fourth intercostal space, that which I told you, right? Based on the cause, the murmur could be either in the right upper sternal border, or it could be one area below the pulmonary area, which will be like left sternal border. Okay, so just because they mention left sternal border, you should not assume no. Oh, aortic area is not in the left sternal border, so it is not an aortic regurgitation. No, it could be either left sternal border or right sternal border. Okay. And then yeah, the space and all, it will vary like third or sometimes fourth. So the left, when it comes to the left side, the space area or one area below, it's going to be like a vague area. Okay, it might be third or sometimes it might be fourth. So you cannot go with the space, but it will be clear when it comes to tricuspid area. They will say fifth intercostal space in the left sternal border or lower left sternal border. But the problem is most of the time they will not tell you which intercostal space. It is going to be like left sternal border. That's it. Okay. So let's see this question. Okay. In this question, you can see that is a let's go with a concept that we said: symptoms, history, and then the murmur. Okay, here the symptom is shortness of breath, pounding heart. Like I told you, you can use pounding heart as a clue for the widened pulse pressure, but as I told you, like it can be seen in the conduction defects as well, palpitation, PSVT, and everything. Um, and then uncomfortably aware of the heartbeat while lying on the left side. Okay, you might think that it is that some kind of AF or a PSVT. No, it could be like a widened pulse pressure, but you see there is a widened pulse pressure. Okay, and which of the following is most likely responsible? I don't think you will find any question with such less clues, like why only the widened blood pressure, I mean widened pulse pressure is the clue here. But that is not going to be case in the actual question. They will definitely give you the murmur. Okay, murmur and location will always be there when it comes to the regurgitant question. But as you can see in all these options, the only thing that is confusing here is the aortic stenosis, because aortic sorry, not aortic stenosis, mitral stenosis. In my case, I feel like either it could be mitral stenosis or aortic regurgitation. The reason in mitral stenosis, there is high chance of atrial fibrillation. Okay, it can be seen in aortic stenosis as well, but it is more common with mitral stenosis. And the one more thing is aortic regurgitation. You have widened pulse pressure, which can cause pounding heart. So basically, the pounding heart can be seen in these two conditions, but widened pulse pressure can be seen only in the aortic regurgitation. So you go with aortic regurgitation. Clear? Okay. I hope that was, yeah. Next one. Next is the best. What is the best next step here? As you can see in the history, as we go with 3 steps in the history, they give routine employment, which means the patient have no symptoms. So it could be possible. Like I told you, if it is symptomatic, it is severe. If the patient is not symptomatic, he still has the disease, but it is not severe and no symptoms, so there's no clue with that, and he has good exercise tolerance and everything. The murmur, yearly diastolic murmur, left sternal border. Okay, so I think diastolic murmur in the left sternal border, it's going to be aortic regurgitation murmur. But the question is not even about that. What is the best next step? I always told you the valvular abnormalities diagnosis, I mean investigation of choice is always echo any valvular disease or any treated valvular disease looking for a complication. Everything echo is the investigation of choice, and the treatment will be usually valve replacement surgery. There's no much of a medical management in this case. Okay, usually it's valve surgery, and usually the investigation of choice is echo. There's no doubt in it. So there's a murmur, it is mostly valvular defect, so you have to do an echo. There's nothing big here. Like I told you, it's an eccentric hypertrophy. The eccentric hypertrophy will cause, I think these are all the same. It is to increase the stroke volume. Yeah. So what are the volumes that increases in aortic regurgitation? Stroke volume increases, left ventricle end diastolic volume increases, ejection fraction also increases. You might, yeah, ejection fraction also increases. Everything increases. The problem is they don't retain it. It comes back immediately as a regurgitant. Okay. So all of these things will increase. Let's see what happens in the next question. So they're asking compensatory mechanism best explains which of the following. So Tom explains why this patient is asymptomatic with the existing pathology. Okay, so here they're saying like there is a heart murmur and he's having some symptoms. So he basically doesn't have any symptom, but he is having a heart murmur, and it is elderly. Okay, you can keep that in mind. But look at the pulse pressure difference in the pulse pressure. It is just widened at this point. Like I'm more towards AR, but yeah, they've already mentioned it that the person is having a severe aortic regurgitation, and they've also mentioned the dilated with the ejection fraction 63%, which we already know that the ejection fraction will be improved. So they're asking what is the compensating mechanism. It's simple. It's just eccentric hypertrophy. Eccentric hypertrophy is increased left ventricle compliance. That is dilatation, right? That's it. Okay, so what are they saying here? High amplitude pulsation with rapid diastolic collapse. Yeah, this is like the fancy way of explaining this widened pulse pressure. And they have given different names. There is head bobbing. With each heartbeat, they have a name for the sign, which is no need of remembering all those things. Remember the head bobbing. They will only explain it in terms of, they will not mention the sign and all. Experience palpitation due to forceful left ventricle contractions, like I told you. That is nothing but increased systolic blood pressure. Yeah, so when it comes to this diagram, I don't think they asked this diagram for step two, but we will quickly see what are the things that has changed from a normal person to the aortic regurgitation person. As you can see in this diagram, the blood pressure, this is the ventricular pressure, right? As you can see, there's a small notch here, the aortic valve closure. This is like when the valve, just give me 1 second. Yeah. So the mitral valve closes. This is like the systole of the left ventricle. So during the systole of the left ventricle, there is also a point where the aortic valve closes, right? And that closure of the aortic valve will cause a small bump. It is similar to that. We saw that JVP, right? In the JVP, the tricuspid closure causes a small bump. That is the C wave, right? It is similar to that. This aortic, that's how I remember this aortic dicrotic notch. The dicrotic notch is similar to that. Okay. The aortic valve closure will cause a similar small bump in the pressure changes in the left ventricle. So that is going to be absent when it comes to the aortic regurgitation. Why? There is no proper closure of the aortic valve at all. It is that phase where the aortic valve becomes weaker and opens up. So that is absent. Loss of aortic dicrotic notch. And the next one is the steep diastolic decline pressure. As you know that here, the regurgitant murmur is going to decrease the pressure in the left ventricle, and that is going to cause the steep decrease in the reduce the pressure in the aorta. That is going to cause a steep decrease in the pressure. There will be the steep wave. And one more thing is the left ventricle end diastolic volume is increased. I told you, right? If the volume is increased, the next thing is pressure is also going to increase. So the overall left ventricle pressure is going to be increased. As you can see here, the pressure is somewhere around 120. The maximum pressure left ventricle will go is till 120, right? Once it crosses the 120, the aortic valve will open and the blood will go to the aorta from the left ventricle. But here the blood pressure is like 150. Can you see that? Why? Because there's so much blood. There's so much blood in left ventricle and diastolic volume, and that has increased the left ventricle pressure as well, and that is going to cause increase in the peak pressure of the left ventricle and also the systolic pressure of the aorta. This aorta, that is the reason for the widened pulse pressure, right? So what are the three changes that we saw here? One is the disappearance of the aortic notch, which is gone here, and there is steep curve here seen here because of the blood from the aorta falling to the left ventricle. And as you can see, the left ventricle pressure is increased. Okay, these are the three changes you will see. And here they have mentioned the pathology. I think it's almost the same. The diastolic blood pressure is falling, which is causing, I told you the reason. The blood is coming back to the left ventricle. And that is one of the reason of widened pulse pressure and increase in systolic pressure. Why? Because of the increase in this left ventricle end diastolic volume. Okay, that is going, there's also one more cause of the widened pulse pressure. And all this left ventricle end diastolic volume increase is going to cause eccentric hypertrophy. And this is a compensatory mechanism, which is nothing but a left ventricular compliance being increased. And apart from that, there are, yeah. So when this problem, any regurgitant murmur, when the blood keeps increasing, even the compensatory mechanism cannot hold it for longer. So this volume increase, pressure increase, at one point the heart is going to give up, which is going to cause heart failure. Okay, so there will be a left ventricular dysfunction, and that is nothing but dilated cardiomyopathy. They're going to have heart failure, which is a dilated cardiomyopathy, because they cannot, this compensatory mechanism cannot go for beyond further level. So that is going, the heart is going to give up at one point, and it is going to cause heart failure. I hope we are clear till here. It is the same concept repeated here. We'll move on to the next one. Are we clear with the AR? I hope no questions should be, yeah, no questions can be wrong after this. I think we covered almost everything. Next is the pulmonary regurgitation. So pulmonary regurgitation, I just don't wanted you to confuse too much. The only place they will ask pulmonary regurgitation, or you will see pulmonary regurgitation question, is after the valve has been repaired. Mostly, when do we repair the pulmonary regurgitation? I mean, pulmonary valve. We touch the pulmonary valve when there is a congenital abnormality which is affecting the valve. That is most probably going to be TOF. So, as far as I've seen, even in the NBME or actual exam questions, if they are going to ask you pulmonary regurgitation, it's going to be a TOF patient, a child with a TOF. He has been operated, and after operation, he is having a regurgitant murmur, pulmonary regurgitation. That is how the question is going to be. They will sometimes mention either TOF, sometimes mention some kind of congenital heart defect which has been operated, and after operation he is having pulmonary regurgitation. Of course, they will not mention pulmonary regurgitation; they will mention the murmurs of the pulmonary regurgitation, and you make a diagnosis. I don't remember seeing any RHD or infective endocarditis. It's like very rare. Okay, it's mostly going to be like. Either this cause, or I remember seeing some places where infective endocarditis being mentioned, because if they are IV drug users, still it's going to be tricuspid regurgitation, but there is also chances of aortic, pulmonary regurgitation, because right sided of the heart is involved a lot with IV drug use, right? So that can cause, that can go on to cause pulmonary regurgitation, acutely present with pulmonary regurgitation, and that could be one more scenario. And RHD sometimes, rarely. RHD could be basically anywhere. It can cause any valve, and that could be, but mostly they will go for MS. As we know, sorry, as we know in exams or NBMEs, they will go for the most common one. So if they mention RST, it's mostly going to be AS, MS, or MR. So if you're suspecting pulmonary regurgitation, it's going to be one of these two scenarios. Okay, either it is going to be a TOF baby who have been operated recently, or it is going to be an infective endocarditis. And the murmur, like I told you, pulmonary regurgitation murmur is similar to the aortic regurgitation murmur. What is that? Decrescendo type of diastolic murmur, right? It's going to be the same. Just the area is going to be different. It's going to be in the pulmonary area instead of in the aortic area. So decrescendo type of diastolic murmur. And remember, one more differentiating factor that we discussed yesterday, I mean, the last class, was that there will be, we saw that the maneuvers can increase or decrease the increase or decrease the murmur intensity, and that is one more differentiating factor which we can use to find the diagnosis of the regurgitant or stenotic valvular diseases. But what the problem is, they don't mention it in all cases, but if they mention, that is one of the clue. And one more thing is with inspiration and expiration. If you really have a confusion, is it like a right side or left side, look at the question, see if there is change with inspiration or expiration. If a murmur is increasing in intensity with the inspiration, then it is going to be a right-sided murmur, right? So that is one extra clue. So when it comes to right-sided murmurs, which is very rare, when it comes to right-sided murmur, we saw the cause, which is very less. Like they're only going to give you a classic case when it comes to right-sided murmur, because they're very rare. Okay, that will be one clue. And second clue is murmur, and the third clue is inspiration. So inspiration or expiration, that can help you differentiate, though they may not mention it in all questions. Okay, and this, as I told you, like pulmonary regurgitation, right-sided murmur, so they should increase with inspiration. And then you will see a soft P2. Like it's the same as the aortic regurgitation. Okay, soft or sometimes absent P2 can be seen. I don't think that's very differentiating. And dyspnea and prominent parasternal heave. Like I told you, aortic regurgitation, because it will cause, we saw like left ventricle hypertrophy and left ventricle heart failure, right? Sorry. Yeah, so pulmonary regurgitation will do the same in the right side, right ventricle heart failure. So left ventricle hypertrophy, you will see apical impulse is getting pushed towards the axilla, right? I hope you're clear with that. That is what you see. The what do you call it? The apical impulse is very strong, or something terms like that, that is mentioned. That is with the apical impulse. That is for left-sided heart hypertrophy. If you see a right heart hypertrophy, you will see the parasternal heave. Okay, that is for the a feature of the right ventricle hypertrophy. Yeah, so it is basically the same thing. Okay. And then you will have dyspnea, but here the dyspnea is not because of the volume overload or pulmonary edema. Here it is because of the reduced blood in the going to the heart, because a lot of blood is getting regurgitated to the right ventricle itself. So you will have reduced blood to the pulmonary vessels, which can cause dyspnea. Dyspnea is because of the hypoxia related thing. Okay. And again, whenever there's a valvular defect, it is going to be echocardiogram for diagnosis, and the treatment is valve replacement. That thing will never change. It's like the simple question that is most probably asked in step 2. Okay, so that thing will never change. So remember it. Yeah. So pulmonary regurgitation is over. So we'll see this question. Okay. What is the most common cause of this patient's symptom? It is a 30-year-old man. He came in with symptoms of dyspnea. Yeah, symptoms is as usual vague. Let's go for the next clue, which is murmur. Murmur is decrescendo type of diastolic murmur with inspiration. Yeah, this it's a like I told you, always the thing that helps us diagnosis is the murmur, and the extra edge will be the maneuvers increasing or increasing decreasing with inspiration. That is like an extra edge. So here is a decrescent of murmur, but the one that increases with the inspiration will be the pulmonary, that is right-sided. So it is pulmonary regurgitation. That is straightforward. Okay, and see, I told you the third clue will be history, right? So look at the history. They said like there's TOF which has been operated at the age of 3, which is the most common cause of the pulmonary regurgitation murmur. Yeah, so third clue is also done. We have two strong clues, so it is pulmonary regurgitation, straightforward. And like I told you, it's the same thing they have explained, the thing that we saw so far, right? Um, yeah, they've also mentioned some things about the TOF. I think the components of TOF by now you should be very thorough. I guess there is right ventricular outflow tract obstruction, which is they also call it as pulmonary stenosis. Sometimes they mention as subpulmonic stenosis. All these terms. Second component is the VSD, and third component is the overriding of aorta, and fourth component is the right ventricular hypertrophy. Right. And this right ventricular hypertrophy is going to cause the prominent parasternal heave, which you can also see with the pulmonary regurgitation, which happens after the surgery. Okay, eccentric hypertrophy, concentric. Yeah, this is like an yeah extra edge. You can remember like the TOF itself will cause what kind of hypertrophy? TOF if it's like a stenotic condition, right? There is some kind of stenosis going to happen. Okay, that is the mostly the infundibular part going in obstructing the left ventricular outflow tract obstruction. This left ventricular outflow tract obstruction is going to cause increased pressure, right? Just like the aortic stenosis, right? This is going to cause what? Concentric hypertrophy, diastolic heart failure, okay? But the pulmonary regurgitation, which is a complication of the TOF surgery, it is going to cause what? Dilated cardiomyopathy, that is systolic heart failure, right? Eccentric hypertrophy. Reason? It is the volume overload. The regurgitated blood is a volume, so it's volume overload. It's clear, right? It's just TOF itself is like a AS, it is going to cause concentric hypertrophy, and if it's like a regurgitation problem, then it is going to cause eccentric hypertrophy, systolic dilated cardiomyopathy, all those things. Okay. Next is the mitral stenosis. With mitral stenosis, as I told you, mitral stenosis most common causes rheumatic heart disease. If it's NBME or actual exam, mostly the question with that will go with rheumatic heart disease will be mitral stenosis. Okay, but you keep your options open because RHD is a cause in a lot of other conditions as well. Almost all of the valvular disease. So you keep that open, but mitral stenosis is going to be more. Okay, and then there could be age related, like like aortic stenosis. Mitral stenosis can also happen age related, and these two things like common that you can remember. That's it. So just make sure you don't confuse mitral stenosis causes with the mitral regurgitation causes. Mitral regurgitation or any regurgitation for that, we saw primary and secondary cause. The primary cause is what we saw like Marfan syndrome, Ehlers-Danlos, syphilis, all those things, and the secondary is what or even the endocarditis, rheumatic heart disease, all these things. And secondary is what the root dilatation thing, right? I think I confused it here a little bit. Yeah. So the primary is what going to be like endocarditis, rheumatic heart disease, all those things, and secondary is going to be the root dilatation, which is because of the Marfan's, Ehlers-Danlos, and syphilis and everything, right? So I hope you don't confuse that with the mitral stenosis causes, which will be mostly rheumatic heart disease and age related. Okay, when it comes to regurgitation, always think of secondary. Secondary will be the most common cause. When it comes to stenosis, it is going to be the primary. That is the calcification which is affecting the valve itself, or the rheumatic heart disease itself affecting the valvular cause. That is going to be the most common cause. And clinical presentation, like I told you, any stenotic, there will be a reduced cardiac output. The reduced cardiac output will cause symptoms like what is that? Syncope, pre-syncope, especially with exertions or exercise intolerance. And it can also be this backward pressure increasing, right? Stenosis, pressure is increasing. So backward pressure increase can cause pulmonary congestion and all those symptoms like dyspnea. And they can, if they go on to develop heart failure, they might have what do you call it? Edema, ascites, JVP elevation, all those things. Okay. Why I'm saying heart failure is more this backward pressure is more with the stenotic condition. Stenosis itself is a pressure overload first, while the regurgitation is a volume overload, and the pressure overload is going to happen next to the volume overload. Clinical technically, if you think, it's going to take a long time for a regurgitation murmur to go on to develop a heart failure, except if it's an acute mitral regurgitation, acute conditions they might cause. But if it's a congenital valvular defect which is causing which is leading to develop a heart failure, it is going to take a while. Whereas the stenotic conditions are more to cause pressure overload, and that is more to cause this pulmonary congestion and what do you call it, backward pressure symptoms, edema. All those symptoms are most commonly seen with the stenosis. But I'm telling you, when it comes to solving questions, the symptoms is vague. Don't go with the symptoms. Go with the murmur and go with the history and look for the other clues. Okay, not with the symptoms. Symptoms will be vague with. Um, yeah, so symptoms will be vague when it comes to the regurgitation murmur. And one more important thing for MS that you have to remember is the atrial fibrillation. So one of the most important cause for atrial fibrillation is the MS. Let's just have a short thing of what is that, atrial fibrillation causes. Okay, mostly atrial fibrillation, when they mention if it's going to be a question of atrial fibrillation, the causes that they will mention in step 2 will be either elderly, or if it's going to be thyroid, or is it going to be hypertension. All this will be the most common causes. But MS, valvular cause, is also an important cause, because valve will increase the pressure in the atria will dilate, and this remodeling will affect the conduction fibers, and that will start firing improper or irregular impulses that is going to cause atrial fibrillation. The problem is valvular diseases are difficult to treat. All the rules and regulations that you see for the treatment of the atrial fibrillation is different for valvular disease, and it is different for the thing that we see that control the rate and control the rhythm. The rate control, you give beta blockers, calcium channel blockers, and you control the rhythm either with cardioversion, or you give the patients electrical or chemical cardioversion. All, and then you give the patient and you look for the Chadwell score, and then you go on to treat the patient with anticoagulants. All this are for the atrial fibrillation, for the other causes, not the valvular causes. Valvular causes, all patients should be given an anticoagulants. Valvular causes, you cannot go on to do the rate control and all those things. The first step is go and treat the valve, because all these treatments, medical treatment, is not responsive for valvular diseases. You have to go and treat the valve first. Go, if it's a mitral stenosis, treat the mitral valve. So that is going to be the treatment when it comes to the valvular diseases. So all the classic treatment that you see for AF is for non-valvular causes, not for the valvular causes. Valvular causes, all patients give anticoagulants, no need of checking the Chadwell score, and all patients should be undergoing valvular replacement as the first surgery, first line of management. Okay, I hope we are clear with that. You understood what I said, right? Yeah. So, okay, next one is what do we say? Yeah. So we just got diverted. So mitral stenosis, one of the important clues apart in the symptoms you will see is atrial fibrillation. So they might mention something about palpitation, pounding heart, and all those things. That's why when I saw the other question about the atrial regurgitation, when they mentioned the pounding heart, which is for the what is that? Which is for the widened pulse pressure, but I got a little confused because I thought it could be atrial fibrillation because of MS as well. But usually mention the murmurs, so that is going to be clear. For MS, I told you the murmur already, opening snap, but they will not mention opening snap. It's going to be a sound after the S2. Okay, and then that will followed by mid diastolic rumble murmur, and the location is apex. Investigation of choice, always echo, and the treatment always is valve replacement surgery done. Okay. So mitral valve involvement, it's the same story they are repeating. Okay, rheumatic heart disease is the most common cause, and you can see it in the younger patients as well, middle-aged patients. Like I told you, it's a pressure overload condition, right? So the pressure in the atria is going to increase, and that will go on to increase the pressure in the pulmonary vessels. That is, pulmonary capillary bed pressure is going to increase, and that will increase the pressure in the venous system, which is going to cause JVP dilatation and hepatomegaly, lower limbs edema, and all those things, orthopnea, all those heart failure symptoms. You will see it here also. But the problem is the heart is not failing. The problem is with the um, left atrium. That is, the pressure is building in the left atrium, not in the left ventricle. That is the difference here. So when you see heart failure symptoms, it could be like mitral stenosis as well. Just keep that in mind. But anyways, we are not going to go with the symptoms for diagnosing. So yeah, so here they mention mild and moderate. So, and severe. Severe is the one where you have heart failure. If you don't have heart failure, if the symptom is only because of the reduced cardiac output, like dyspnea and exertion and everything, it's going to be mild or moderate. That's what they say. Yeah. So hemodynamics, it is the same story that that's getting repeated. Like there will be increased pressure in the left atrium. Yeah, stenotic mitral valve. There will be increased pressure gradient between pressure gradient is the difference between pressure. Increased pressure in the left atrium, the gradient will be also be increased. Okay, the left ventricular pressure is lower, so the gradient is getting increased, and the left ventricle filling will be decreased, right? So that is what is the cause of reduced cardiac output. Okay, and the left atrial pressure increase, it's going to cause the pressure is increasing, and there is also some stagnation of blood, right? And that is what is going to cause the atrial fibrillation. And if there is a fibrillation, there's always increased risk of thrombus. Okay, so there is also that is also one more thing. That's why we are giving anticoagulant in all cases of AF with MS. Okay, there's no need of going to CHADVAS score in these cases. If you see AF with an because of an MS, it's going to be you have to give anticoagulants. No need to check the CHADVAS score. Um, Next is the pulmonary venous congestion, pulmonary edema, which we mentioned already, pulmonary hypertension. This is a cause of secondary pulmonary hypertension. We'll have a quick word about what are the causes of pulmonary hypertension. So, what is the primary? There are like one, two, three, four, five, right? There are a lot of types. One is the simple primary pulmonary hypertension. There is some defect in the endothelial layer of the pulmonary vessels that is going to cause hyperplasia, smooth muscle proliferation, and that is going to cause hypertension. That is primary. The second type 2, it is the pulmonary venous hypertension. That's how I remember this. It is not actually blood arteries that is getting dilated. That is the pulmonary veins are getting the having hypertension. The reason is the pressure is coming from the, it could come from the left atrium. MS is one such type. MS is like it can cause type 2 pulmonary hypertension. And then type 3 is the COPD or any other lung disease, lung pathology causing pulmonary hypertension is the type 3. And type 4 will be like I think it's sarcoidosis or something, but these three are important. So MS is more common, most associated with type 2, which is pulmonary venous hypertension, right? Yeah, that is also one more thing you can remember. And then if it like if the pressure keeps on and keeps on, if the all the way, if it goes to the tricuspid, it can cause tricuspid regurgitation as well, and it can cause left ventricular pressure and pressure overload, and that can go on to cause right heart failure as well. So if at all if a MS patient is going on to develop a heart failure, it is going to be right heart failure, not left heart failure, because the left heart is waiting for the blood to come in. So there is not going to be any defect in the left heart or left ventricle function. It's going to be a right heart failure. Okay. Yeah, so there will be loud S1. In a loud S1 is because of these stiff leaflets. Okay, so remember always when any stenotic diseases, when you see a loud heart sound, it is going to be less severe disease. If you see a soft heart sound, it is going to be a severe disease. Remember, we saw AS. There are I said three findings which are classic with the very serious AS. One is the late peak, and the other one was what was that? Yeah, soft S2, right? Soft and single S2, right? So here it is going to be the same concept, soft S1. Instead of S2, it is S1. A soft S1 is an indication of severe disease. Okay, I hope you got it. Um, Next is the left ventricular diastolic pressure and afterload, which is also like normal because as I told you, left side, it's all the same thing. And in severe MS cases, there will be, this is like too much of information. Increase sympathetic activity to increase left ventricular contraction. The problem is that they don't, the left ventricle is not contracting at all. So cardiac output is decreased. Systemic vascular resistance is decreased. So that is going to cause, sympathetic activate the baroreceptors and everything from the aorta and everything, and that is going to cause excessive adrenaline, everything pushed into the system. Sympathetic activation. The sympathetic activation in turn will cause left ventricle contraction as well. To everything is an attempt to increase the cardiac output. I don't think they will ask any questions here. Yeah, so next one is like they're mentioning some increased pulmonary artery pressure. The reason for that, so like I told you, the pulmonary artery pressure, pulmonary hypertension is most commonly because of the backward pressure, right? They're mentioning yet another concept. This is the passive or post capillary component. There is one more concept for causing the pulmonary hypertension in patients with MS. The reason is this MS itself triggers some endothelium mediated pulmonary arterial vasoconstriction, it seems. So that can also go on to cause the pulmonary hypertension. At the end of the day, if they ask a question, they might give you a clue about pulmonary hypertension. They are definitely not going to ask which component has caused it because nobody knows all those things. Yeah. Next one is upward displacement of lip. Sometimes you might see in a chest X-ray, but in chest X-ray to find a pulmonary artery itself is difficult. But if you do find it, And in this MS patients, you might see that it has been displaced upwards. Why? Because of this pulmonary hypertension, right? That can displace the pulmonary artery component. Uh, and that can, this pulmonary hypertension, this can, enlarge the pulmonary arteries. And there is, the left bronchus is the pulmonary artery is going below the left main bronchus, right? So that can push the left main bronchus upwards in seats. But I have never seen a question which is mentioning all these things. We'll move on to the next question. So here there is a yearly diastolic heart sound, which is best heard with the diastolic rumble. Diastolic heart sound with the diastolic murmur on the left side of the heart. It is mostly going to be, hello. Yeah, yeah. So if it is mostly going to be the MS, sometimes the call just cuts without any uh, clue. That's why I'm just checking now and then. Yeah. So left side of the heart. So it is going to be MS. Let's see if there's any extra clue here. Several years of shortness of breath with exertion. Progress. Yeah. So it's a progressive disease. This is not a specific clue. That is puffiness of the both ankles at the end of the day. So it is some kind of stenotic disease. Okay. And there could be dyspnea even at the rest. Okay. So Disney, even at the rest, yeah, this is also not a very specific clue. And they have immigrated from India at the age 20. This is like a very specific clue. So we have like murmur clue, which is also specific, and there is a history RHD, which is also specific. So it is mostly MS. And what all increases pulmonary artery systolic pressure will be increased, pulmonary artery diastolic pressure is increased, left ventricular diastolic pressure is either normal or decreased. Okay. So the option is B. There is no confusion here. And what the thing is, they're saying like if the MS murmur, sometimes there could be the parameters could be normal. They're saying in that, 1 second, but not volume overload symptoms, then it could be parameters are said to be normal. So what they're saying is like if it's a less severe form of pulmonary mitral stenosis, the parameters could be normal. That's what they're saying. But they're not going to ask a question with this. Mostly they will ask this question, which is like the pressure is increasing in the backward direction, so that can cause an atrial fibrillation. You will see irregular rhythm. And the okay, can you tell me what is the treatment for the which place will you give the electrocute? Will you electrocute to correct this atrial fibrillation? What is the origin, or in other words, what's the origin of the AF signals? It's the pulmonary veins, right? You know what? Yeah, so let's just keep it clear. Atrial fibrillation, the problem, I told you like atrial fibrillation, the problem is in the left atria, right? Left atria is dilating. That is the most common problem. Like, look at the causes of atrial fibrillation. All the causes we mentioned so far, it is going to cause problem with the left atria only, like hypertension, and then even the elderly people, all these things are going to cause the pressure in the left atria to increase, not the right atria, right? So all this, and even the valvular causes like MS, all these are going to increase the pressure in the left atria. So which means if the left atrial pressure is increasing, that is causing AF, then the ectopic pulse should originate from the left atrium, right? And exactly to be more accurate, it is around the pulmonary veins. Okay, there are four pulmonary veins opening into the left atria. It's around these pulmonary veins this ectopic signal is going to originate. So when you ablate the signals, it has to be like around this. They will usually do a electrocution and ablate around this. Pulmonary vein. So if there is any signals coming from there, it will get like you can actually block those signals. That is the concept for left atrial fibrillation. But when it comes to atrial flutter, that is when the right atrium comes into play. So that is where there is something called the region where the inferior vena cava opens into the right atrium. Nearby that, there is that is the most common location for the origin of the atrial flutter. Even though the atrial flutter and fibrillation both will have similar ECG findings, symptoms, and everything, the origin is different. So when you do a surgery, that is when you have to differentiate if it's a flutter or a fibrillation. In that case, the surgery will include the electrocution of the right atria, usually they will just obliterate a line or in the right atria. Okay, so like if you let's say the signals are originating here or here, you just block the signal. You just cause myocyte. You just electrocute the myocytes in a single line, and that will block the signal. Coming from the ectopic site. So atrial flutter, it is right atria. Atrial fibrillation, it is left atria, mostly around the pulmonary veins. So the procedure will involve in electrocution of the right atria. Okay. That is one more important thing that you have to remember. And atrial fibrillation with itself, even without this valvular defect, atrial fibrillation is going to cause a decompensated heart failure. The reason is atrial fibrillation will cause very high heart rate, right? It's only the only thing that is preventing the heart rate that is giving maintaining the cardiac output in case of atrial fibrillation will be the AV. The AV node as some kind of block. It is like a slow. It is like a grandpa. So how much ever the signal comes, it will be like I will send only one signal at a time. Okay, so that delay is what is going to cause the maintain the output, cardiac output. So even if the 150 or 200 signal comes from the atria, it's going to transmit only like 80 or 100 signals. So that 80 or 100 signals will maintain the will maintain the heart rate. That will give enough time for the ventricles to contract, and that will maintain the cardiac output. But what happens as age goes, the AV node also becomes like even more sorry not with age. In young patients, what is this? The AV node is like not as sluggish as the older patients. The AV node is generally sluggish, but in younger patients it's like unwantedly functioning so well. So what happens is, if there is 150 signals, let's say 120 signals are transmitted, so this will cause increased ventricular heart rate as well. Ventricular heart rate also increases. That will reduce the diastolic time, and the diastolic time reduces, diastolic filling is also reduced. Diastolic filling is reduced, cardiac output is reduced. Okay, and so if the diastolic filling time is reduced, then this is going on to develop what? Tachycardia induced cardiomyopathy, right? One of the causes of dilated cardiomyopathy is tachycardia. Remember, there is like viral cause, there is volume overload cause, and one more cause is tachycardia. So tachycardia induced dilated cardiomyopathy can also be seen in atrial fibrillation. So they are saying like even atrial fibrillation itself can induce your decompensated heart failure in these patients. That's what they're saying. And one more thing is, if MS patients goes on to develop AF, it's even more worse. The reason is because in MS patients already, like, there is some block. Whenever there is a diastole happening, the blood should come from the atria to the ventricles, right? There are two components to this diastole. One is the passive component. Passive component is just the valve opens, the gravity itself pulls the blood, and that will cause ventricular filling, right? Second component is the atrial kink. That is when the atria actually contracts, and that pushes the blood from the atria to the ventricles. That is the second component. Anyway, in the stenotic components, first component is absent. Why? Because the valve is stenos. No, even there is gravity pulling, there is no space for the blood to move. Okay, so the mitral stenotic patients are mostly dependent on the atrial kick. That is the atria to contract to push little bit of to push the blood against the stenotic valve. Okay, but what happens in AF? Remember, I told you when explaining S3 and S4, AF will not have S3 and S4 because they don't have atrial kick, right? There is no atria contracting at all. Just there is like continuous what is that? Continuous signals coming. The atria is just fluttering, fibrillating. It is not contracting at all. So the kick component is gone. So the cardiac output even more decreases in MS patients with atrial fibrillation. It's very worse, right? And the MS patients depends on the atrial kick for the diastolic filling of the left ventricles. And if the atrial fibrillation absence, even the kick is gone. So even the atrial kick is gone. So there is no blood coming to the left ventricle at all, and it is like a very severe conditions. That's why, like, if a patient, in terms of clinically when speaking, if an MS patient goes on to develop atrial fibrillation, or if you find that the atrial fibrillation is caused by the MS, then the chances of the patient recovering is very low, that they have a very high mortality rate, because there is no particular treatment for that patients, and they are like can go in for like cardiac arrest anytime because of the very low cardiac output. Okay, that is one more concept I want you to remember. And atrial fibrillation, the setting of carries high thrombosis. Remember, if there is no atria contracting at all and the blood keeps pooling up in the atria, then the thrombosis, there is high possibility of having a thrombus. So that's why I told you, you don't do Chadwa score for MS patients with AF, you just go on to give them the anticoagulants. Okay. Let's see what this question is about. On examination, there is a yearly diastolic murmur. So I usually go with murmur first. So diastolic murmur followed by a bit diastolic, yearly diastolic sound followed by a, like I told you, right? They didn't mention opening snap. They only mentioned yearly diastolic sound. Okay. It could be a sound next to S3 or S4 yearly diastolic. That's how they mention it, all these sounds. And they also mentioned that the patient is having palpitation and he's having a racing heart. If this palpitation is associated with a diastolic murmur, then it's going to be like MS with AF, right? So they're asking like which of the following is most likely finding on echocardiogram. You will see left atrial dilatation because if the MS patient is developing AF itself, which means the left atria is undergoing some kind of changes, like anatomical changes has been undergone in the left atria. That is why what has affected the conduction fibers, and that is what has caused the AF. Okay, so left atrial dilatation is the answer for this patient. And yeah, so it is a case of AF with MS. Okay, and we'll see what the next question is about. Which of the following is most likely diagnosis? The patient is having left-sided hemiparesis, left-sided weakness that start. We want to differentiate from what? Option C. Oh, okay, sorry. So left atrial mass attached to left intraatrial septum. Yeah. So the left atrial, if there is a mass attached to here, what they're saying is the what is that plopping sound? What do you call it? Myxoma. Yeah. So they want to say myxoma here. If there is a myxoma, like um, let's say the myxoma, let's see the concept of the myxoma here. Myxoma is nothing but a growth. Okay, the growth is in the left atria. This, it's like a huge ball of growth. It's actually a benign one, it's not a malignant one. Any heart any malignant disease in heart is benign. There's no malignant disease in the heart except metastasis. So this huge ball, what they will do is two things they can cause. Okay, first problem that will cause is this ball can go and obstruct the mitral valve. I mean, it will just prevent the mitral valve from closing. That can cause mitral regurgitation. One problem. Okay. Second problem is this ball will completely collapse into the mitral atria, and it will completely block the mitral valve, and it will completely block the mitral valve, and that will cause sudden cardiac arrest. And that is the second problem. They can cause sudden cardiac arrest because the mitral valve is completely blocked, or it can cause mitral regurgitation because it is preventing the mitral valve from closing completely. These are the two things that you problems you will encounter with the myxoma. That I mean, yeah, so this one second. Yeah, so this makes so much. These are the two problems. But what one more thing that the diagnosis you will do is using the echo. When you do the echo, you will see this large ball that is the atrial mass that is attached to the intraatrial septum. That is how they will make a diagnosis. It's not coming from the atria free wall. It is coming from the intraatrial septum. Okay, this is all the questions they will ask in myxoma. There's no other questions. Okay, if you go for pathologically, I think in step one they might have something related to the what is the if you take a biopsy, what you will see mixinetous degeneration inside that. That's all the thing they will ask. But this question has no reason to suspect myxoma here. It's not that the patient is not having a cardiac arrest. The patient is not having a mitral regurgitation. And in echo, we didn't. Yeah. So we didn't find any features suggesting of these two things. So there's no reason to suspect a left atrial myxoma in this patient. Okay. So that's what they're saying. Myxoma can obstruct the mitral valve and can present similar to, like I told you, it can obstruct the mitral valve and cause MS, present similar to MS, but that will be mostly in favor of the what do you call it? Cardiac arrest. Like if a myxoma prolapses, think about a huge ball obstructing the mitral valve. It's like mostly going to cause a cardiac arrest instead of causing a symptom similar to the MS. But one more thing is there will be a classic sign in case of myxoma. That is, there will be a plopping sound. They will mention it most of the question. I think 99% of questions with myxoma will have like they mention like something called plopping sound. There's two things that they will definitely mention when it comes to a myxoma question. Either it is this plopping sound, or they will give a echo finding itself, which is like an intraatrial septum there is a mass. These two things they will mention it. So that's what they're saying. Like if it's a MS, if it's a MS because of this myxoma, you will not see an opening snap. Would not be present. It is opening snap is like the problem is in the valve. It's not external obstruction, right? The concept. I think you're clear with that. So yeah, you can see a thrombus can be seen if it's in a myxoma because myxoma is like a foreign tissue, right? It's not a cardiac tissue. So that can cause thrombus. That can be seen sometimes. But anyway, opening snap is not seen. This is like a classic MS case instead of a myxoma causing a MS case. I've never seen a myxoma presenting in the form of MS. It will present in the form of MR, or it will present in the form of sudden cardiac arrest. Okay, that's how they give. But mostly they give the clue like popping and sound in the popping heart sound, or they will give echo finding, which is a mass in the intratrial septum. So I don't think this is. There's no reason to confuse it with the myxoma here. Yeah. Do you have any other doubt? I think all the other features we already covered. Left ventricle is not dilated, which will be small because there's no volume or pressure overload in the left ventricle. Left ventricle will not undergo hypertrophy because only right ventricle undergoes hypertrophy when it comes to mitral stenosis, because there is no pressure increase in the left ventricle or even volume. And atrial septal defect, there's no reason for atrial septal defect here. Okay. Yeah. Any other doubts in this question? Can we move on to the next one? Yeah. Okay. So can you tell me what are the points I told you with atrial? What is the clues for the myxoma? Left atrial myxoma? Yeah, sudden cardiac death. And you will see the echocardiogram finding as well. Mostly that will be the clue. Okay, so yeah, we'll move on to the next question. I just want to finish two more pages at least. Yeah, so there's a left-sided hemiparesis in this patient, like left-sided weakness, and he has a progressive dyspnea, nocturnal cough, occasional hemoptysis. These are all like pulmonary congestion symptoms to me. There is palpitation and irregular heartbeat, and there is a history of immigration. Okay, so which of the following is most likely diagnosis? They are saying, look, in this case, they didn't mention about the murmur component. Okay, they left it out, but they gave a clear clue with the symptom and cause. This also happens sometimes. Here they mention it is cause similar to rheumatic heart disease. So emigrated, so rheumatic heart disease, most common is MS. So I'm keeping MS in my mind for now. And then when it comes to symptom in MS, the most common symptom will be reduced cardiac output symptoms or increased backward pressure symptoms and AF symptoms. We have all these symptoms. Like the patient is having thrombus, which is, I mean, there's an emboli, which is causing left-sided hemiparesis, which is common with AF, and he is also having palpitation with irregular heartbeat itself gives a important, straightforward to AF only. So we have AF. Okay, most common cause of AF in a valvular disease is MS, right? Again, it is going to MS. And one more thing is like he is having backward pressure symptoms as well, like exertional dyspnea, nocturnal cough, occasional hemoptysis. But again, it's like a vague symptom. But all of these things leads to MS only, right? Even though the murmur is not there, it is like it is more towards the MS, right? But even if you wanted to get confused, like if is it an ES, like even RHT can cause is it like an ER? Even RHT can cause ER, and even ER can cause pounding sensation and everything. But there is no like what was I saying? Yeah. So there is no like you can even think about aortic insufficiency, but remember in aortic insufficiency you will not see left-sided hemiparesis. Insufficiency is like a volume overload. There's no blood stagnating there, and there is no like thrombus or emboli formations there. So I don't think any other option doesn't make any sense. Like it is nowhere related. So we'll move on to the next one. So here there's like most likely cause of the patient's presentation. Let's see what they have mentioned in the symptoms. It's like cough, dyspnea on exertion for the past 3 months, progressive worsening, shortness of breath, unable to lie flat, which is orthopnea. Okay, and he has had palpitations before. Okay, and he immigrated from the Southeast Asia. This is some immigration. There's history component is like mostly towards RHD. Okay, and I keep MS in the whenever I find a RST history, I keep MS comes first in my mind. Okay, so that is on the top. Still, we will see what are the symptoms they have mentioned, and the patient has BMI. Okay, and one more thing is we also didn't find like the BP is normal. There is no increase in pulse pressure. Mm, yeah, so there's an enlarged cardiac silhouette with vascular congestion. You might think that this enlarged cardiac silhouette means that the patient might be having like what do you call it, left ventricular hypertrophy. No, not only left ventricular hypertrophy causes cardiac silhouette increase. Even the left atrial dilatation will also be seen in the X-ray as a enlarged cardiac silhouette only. Okay, so that also you have to keep in the mind. And there is vascular congestion as well. And they have mentioned this rare clue, which is like a left main bronchus is elevated. If the left main it doesn't indicate MS. It just indicates that the pulmonary artery is getting dilated. What is the condition in which pulmonary arteries get dilated? It is undergoing some kind of backward pressure is there. So far all the symptoms are towards like some kind of pressure from the left side of the heart. It is going all the way behind. But the important clue is the irregular rhythm, which is AF. Okay, the valvular disease associated with RHD that can cause AF will be MS, right? Yeah. So most common presentation, it is the RHD. You don't even have to find if it's an MS or not. It's like they're asking what is the reason. It's like a rheumatic heart disease. Okay, like always keep this what do you call it? Flow chart in your mind. And murmur and the you know increase or decrease in murmur with maneuvers. That thing, and next is the history, and next is the symptoms. And the extra clues. Extra clues like AF, it's for MS, and if it is like increased pulse pressure is for AR, and all these are like extra clues. So look for the murmur. Murmur is given straightforward. Just confirm it with the other two things. Make a diagnosis. There's no murmur given. Look for the history next thing, and look for the extra clues. If you find any of these things, confirm it and then make a diagnosis. Symptoms, always keep it in the back. Don't go completely with the symptoms. Mostly symptoms, the thing that will help you is the backward pressure increase. You see edema, orthopnea, all those things. Then it is most likely going to be a stenotic disease, heart failure, impending heart failure. That you can use it, but it just keep it in the back of the mind. Don't go on to diagnose with symptoms alone. That's what I'm saying. So what are the different forms in which MS can present? It could be a straightforward MS question itself, which is saying murmur, and there is a RHD history, and there are some symptoms. That's it. Or it could be MS with heart failure. Heart failure is that the patient will go on to develop like orthopnea, and there will be JVP dilated, and there will be edema and everything. Then it's a MS patient going in for a heart failure. Okay, and or it could be an MS patient with atrial fibrillation. They will mention the MS murmur and history, and they will also say the irregular rhythm, pounding heart pulse, and they will also mention something about the emboli formation, stroke, or some other embolic manifestations. All those things can be there. Or it could be an MS patient, yeah, MS patient AF with an emboli or thrombus. Okay, so these are all the different questions you will get in MS. Okay, MS is like the most important valvular disease. That's why I went a little longer in this. So either it could be simple MS, or with the heart failure, or with an atrial fibrillation, or with an atrial fibrillation and an emboli. These are the different forms of questions you might get. Okay, but remember, always remember echo, always remember valvular surgical valvular repair. That is the treatment and investigation of the choice. Keep it clear. Okay, let's see what is this question. Which of the following is most likely diagnosis? It's an atrial fibrillation with rapidly irregular response. Okay, primigravida mother. This is a OBG. Okay, emergency department, sudden onset severe shortness of breath, fluttering sensation in the heart. So it's a mother. It's a pregnant mother going on with the AF. What is the cause of the AF? We have to find it. Okay, so dyspnea, dry cough, inability to lie flat. All of this are features of a backward pressure increasing pulmonary congestion symptoms, right? But it can happen with AF alone. You don't have to be like MS to be having this symptom. Significant recurrent throat, yeah, this is the extra clue, right? History gave us the clue. Extra clues leading to the MS, right? There is RHD with AF with valvular disease. Then it's going to be MS, right? Yeah, so MS. There's no reason to confuse it because hypertrophic cardiomyopathy, it will be like an athlete going in for cardiac arrest, and they will not have AF and all. AF association is very rare. It's yeah, even if they tend to have some involvement in mitral valve, it's going to be mitral regurgitation because of the what is SAM? Systolic anterior motion of the mitral valve, right? The infundibular, I think I'm going too much into out of topic, but still just see the one point. So in the interventricular symptom, the infundibular part is which is getting affected here. So what happens is this, it will cause obstruction, left ventricular outflow obstruction, right? That is the most common pathology, okay? But it can also pull this mitral valve, right? During systole, it can irregularly pull this mitral valve. That is what they call is systolic anterior motion of the mitral valve. Okay, and that can go on to cause MS in HOCM patients. So even if it is going to be HOCM associated mitral defect, it's going to be MR. It's not going to be MS. So AF is like not possible. Constrictive pericarditis will have right heart failure symptoms. There is no reason for left heart to be involved. No reason for AF. Okay, aortic insufficiency like aortic insufficiency. RST is like not a common cause for aortic insufficiency. Aortic insufficiency should have a widened pulse pressure, which is not here. Pulse pressure is, the diastolic pressure is like low normal, and even the systole is normal. So there's no normal pulse pressure. So that is also not going to be the cause. And postpartum cardiomyopathy, like she's 29 weeks. Sorry, peripartum cardiomyopathy. Peripartum cardiomyopathy patients will tend to have heart this dyspnea, dry inability to life, orthopnea, all those symptoms, but they are not like, it's not going to cause AF in these patients. Okay, and one more thing is, they are not. It is not related to RHT at all. So there's no reason to mention that RHT history here. So um, all these things points to MS in this patient. Okay, I'll see if they've mentioned anything new. They're saying like a new atrial fibrillation with the right ventricle, a rapid right ventricle response with the RHT history is going to be MS, because most MS patient, I told you, like not going to be symptomatic. If there is like congenital, it's not going to be symptomatic. But what happens in pregnancy? The volume increases, right? The blood volume increases. The heart has to function more efficiently. There's more blood volume. There's more blood that is going to be stagnated behind this stenotic valve, that can present as AF, and that can go on to develop MS symptoms, and they can go on to develop AF. Okay, so even though if the patient had a mild MS which was asymptomatic, they can go on to become symptomatic and develop heart failure and AF with pregnancy. Okay, so that's what they've said. Like during pregnancy, there is increased in heart rate and blood flow. In pregnancy itself, will have increased heart rate. That can also precipitate AF. Okay, and there is increased blood volume. All this causes increased pressure gradient between the left atrium and the right ventricle. Right, sorry, left ventricle. Right, so that can go on to worsen the symptoms, and that can go on to develop AF. Okay. What other questions? Yeah, we will just stop with this last question. Which of the following is the most likely cause of this finding? Okay, there's here. Look at the murmur. It is like a straightforward low pitched diastolic murmur at the apex. Just murmur itself is enough. It's a mitral stenosis. You don't even have to go for the history. In this case, history or symptoms. It's just straightforward. Okay, got it. Can we stop it here? Hello. Yeah, yeah. Tell me. No, it's just like 120/80, right? There's like no such thing as low normal range. You just, yeah, we have a high normal. We say that 120 to 130, we have 130, 190 is like a thing to develop hypertension, but there's no such thing as low normal. Even with, if you, no low normal for diastole, even when it comes to patients who are having like, excessive blood loss following trauma and everything, if we have to see if the patient is having hypovolemic shock, even in that case, we look for the systolic blood pressure. Systolic blood pressure less than 90, we call it as hypovolemic. The patient is going in for hypovolemic shock. So diastole, anyway, lesser, like, there's no low normal range. You just see multiple questions and you come up with, yeah. So, but you don't have to know about the low normal range of diastolic blood pressure. Just 110 minus 60 is equal to what? 100, and it's like 40. So this is like an almost like a norm. Yeah, 40 or 50. Yeah, sorry, 50. Bad with math. Okay. So it's anyway in the normal range of pulse pressure, right? So I don't think, you don't have to like look for the normal range of diastolic blood pressure. The only time when you will want to know the normal blood pressure is it's a hypertension, or if the patient is going for a hypolimic shock. Hypolimic shock is like less than 99, the systolic blood pressure. That's what there's a huge debate going on in Reddit about this concept. Like some patients, they mention like the hypovolemic shock. They mention like systolic blood pressure is like even more than 90, and they mention the patient is having hypovolemic shock. How is this possible? Yeah, in that case, you will have to look at the heart rate. If there's a, even if it's like systolic blood pressure is somewhere around 90 or 100, like heart rate is going around like 130 or 150, then, and there is a history of trauma in this patient, or you're suspecting, then it's hypovolemic. It's like you have to combine this common sense and everything. It's like not stick to like less than 90 only is like hypovolemic shock. That's not the actual case, right? When a patient is uh, I've never encountered any confusion in this concept, but I have seen people discussing in Reddit that they are getting confused if the patient is actually having hypolimic. No, what tell you is don't go by like very factual when it comes to here. Like if the patient is having systolic blood pressure less than 90, yes, he's having hypolimic shock. But even if it is not less than 90, if the patient there is a history, there is the if the answer is somewhat towards hypolimic shock and the heart rate is increased, the systolic blood pressure is little in the low normal range, then it's still hypolimic shock. Just stick to that conceptual thing, not like a very factual when it comes to this concept. Okay. Yeah. Um, okay then. So we will start tonight. You want 6 o'clock or 5 o'clock? Which is fine for you?